Good morning or good afternoon or good evening, everyone. Actually, I think, Darcy, are you going to get us started?
Yes,
So I'll if you want to introduce yourself, Darcy. And
sure. Sure. I'm Darcy Richardson. I am a TB consultant. I've been working with GH Pro on this project, and I was the lead consultant for putting together the package. Lisa was our epidemiologist on this pilot program, and we are very happy that you have joined us today. Today, we're going to be talking about how do you actually operationalize the comprehensive care package for people with drug-resistant TB. So what do you do to plan for implementation at the national level? And I put this picture on this first slide just to show you that it actually requires a number of different stakeholders to be able to do this successfully. We had the national program at this particular workshop in China, along with our pilot site staff, including frontline providers, the implementing partner, patient representatives, and a number of others who were involved in this process. Next slide, please. So what we're going to talk about today is just a quick review of what is the framework for comprehensive supportive care for people with drug-resistant TB. Just as a reminder, I'm going to go over steps in the planning and implementation process at the national level. So what do you need to think about when you're planning this at the National TB Program? Lisa is going to speak to considerations for monitoring and evaluation. So how do you measure your success and your progress in implementing supportive care? And she's going to cover some of the keys to success that we found when we did this pilot in 4 countries, including China, Pakistan, South Africa, and Ukraine. I'm just going to point out some resources, and then we'll have time for questions and answers. Next slide. So this is just a little reminder about what the comprehensive supportive care framework looks like. There are 4 thematic areas here. The first one is respecting patient autonomy and supporting self-efficacy. So how do we support patients to make their own decisions about their care? Second area is maximizing physical comfort, safety, and wellness. So what are all of the things that we do that cross over into the medical realm but are still required for supportive care to be successful? The third thematic area is providing psycho-emotional support and protection from social isolation or discrimination. So all of those interventions you think about, like peer support groups, counseling, etc. And then the final area is preventing catastrophic cost to patients and families. So these are the 4 thematic areas that cover all of the supportive services that patients could need. Hit one down, please, Sharanya. There we go. Keep going. Thank you. Okay, perfect. So these are the 13 comprehensive care elements, the 13 elements of care that we concluded were important in looking at the literature, in talking to patients, and in looking at what's worked. So the first area is having a patient assessment and care plan at the very beginning of care so that you can assess what every individual needs or wants to help him or her through treatment. Second area is education and treatment literacy. Third is being able to treat somebody at a location of their choice or as convenient as possible given the organization of the health system. So thinking about outpatient services, ambulatory care, or care in a facility that's closer to their homes. Then under physical comfort and safety, it's monitoring of side effects, providing nutritional support for the patient, him or herself, monitoring and treatment of comorbid conditions that can affect people's ability to get cured, physical rehabilitation after cure, so if people have experienced permanent side effects, hearing loss and other things like that, and palliative and end-of-life care for people who cannot be cured. And then under psycho-emotional support and protection from isolation, we have communication, especially between patients and providers. So compassionate and respectful communication in two ways. Monitoring and treatment of any mental illnesses, especially depression, which is common in people with drug-resistant TB. Addressing social isolation and the need for emotional support through peer groups, counseling, etc., and protection from stigma and discrimination through community outreach work and education of community members, through legal means, etc. And then finally, financial assistance under preventing catastrophic costs to patients and families through direct financial support, through indirect financial support for things like transportation vouchers or care packages, food packages for families, etc. So that's the framework that we're operating in. And what we're going to talk today is about how do we operationalize this at the national level. Next slide. So in doing so, there are really 4 levels that we're looking at. We're at the global level, we're just agreeing that the framework that I just presented is covering the areas that we want to cover. Then at the national or regional level, we take this package and look at what we're doing right now, because you're all doing things in your countries to help people with drug-resistant TB get through treatment. This is just a way of organizing those interventions into a comprehensive whole and seeing where you might have gaps. Excuse me. So once you take a look at what is the status of patient care in your country and where might there be gaps, you decide what interventions would be feasible for the program to implement to cover the elements of the care package. And then you create an appropriate package of supportive services for your circumstances. What are the things that people need the most, want the most, and where are there gaps in coverage that you can fill? Then you go down to the local or facility level and you tailor that package even further, and we'll talk about that in a subsequent webinar. And finally, you get down to the individual patient level, where we use the patient assessment and care plan to be able to translate that into something that an individual patient needs and wants. Next slide, please. And this is what you're going to end up with at the end of this process at the national level. This is an example of what one of our pilot countries did. So you take those thematic areas and the elements, and you decide for your particular setting, what interventions are you going to implement to cover those elements. And as you see here, in red, number 7 and number 8 weren't fully covered for this country because they didn't have the resources and they didn't have the trained staff to be able to implement those elements yet. So those are things that they're working on in future. So the point of this is really that there are many things you're already doing that can fill in some of this table, but there are also areas that you may be working towards and aren't covered completely. So you don't think that you have to do everything at once. Okay, next slide. So there are 10 basic steps in the implementation planning process at the national level. These are not necessarily sequential, so you may be doing more than one of these at one time. You may start with an advocacy strategy and not end with it, because we want to start that at the very beginning of the process. But in general, these are the things to think about. The first is identifying who your stakeholders are, who needs to buy into this process to make it successful, orienting them to the supportive care framework, and making sure they're on board with moving forward. Then identifying a task force or working group to develop, revise, and then finalize your supportive care package for the national level, and getting stakeholder agreement on the package. That's important. The next step would be analyzing your policy, human resource, and material needs to prepare for implementation. So what do you already have in place, and what might you need to get to make this successful? Then making sure that the supportive care is incorporated in your national guidance documents, any protocols you have. Legal frameworks may be important as well. choosing locations where you're going to start implementing the care package or where you're going to expand, and having a set of criteria for doing that, developing your plan and your budget, identifying your funding sources and getting funding to do this, and then planning how you're going to do monitoring and evaluation and using those lessons learned to improve upon your services. And then I would suggest from the very beginning, as we learned in our pilot countries, it's important to develop an advocacy strategy and plan for the sustainability of these services from the very beginning. And we're going to talk about each of these in a little more detail now. Next slide, Sharanya. Okay, so the first thing is identifying who are your stakeholders and making sure that they're oriented to the supportive care framework that I just showed you. Obviously, it's the National TB Program, but it may also be other divisions at the Ministry of Health. It could be other government entities that are responsible for finance or allocating resources, so ministries of finance are often very important. Your technical partners on the ground, and any local implementing organizations and community partners that you might want to engage in this process who can provide some of these services. Private health services, professional organizations, academic institutions that can help you with some research, corporations or other for-profit entities that might be able to sponsor some of your interventions, donors, obviously, and affected community representatives, first and foremost, who are the experts on what supportive care needs to look like. And the point of having all of these stakeholders engaged in the process is that the National TB Program is never going to have all of the resources necessary to cover the services that patients may need or want to be able to complete treatment. So engaging these stakeholders early can help with buy-in so that they are willing to support implementation of some of the aspects of care. Next slide. That picture on the side just happened to be a consensus building meeting from Pakistan, where the NTP went out and actually met at the local level with people who were going to be engaged in the process. So again, a lot of communication is very important in this process. Next slide. The next thing to do is have a working group or a workshop to develop the package of services you want to offer. And that is based on your epidemiology, what patients in your country need or want, and the feasibility of implementation. And the photograph here is actually a workshop at the national level in Ukraine to talk about ambulatory care and what services would be needed. So you need to look at the epidemiology of drug-resistant TB in your country, who is at risk for drug-resistant TB, where do they live, are there geographic areas where it's more concentrated than others, are there certain populations that are more concentrated than others? How are you doing on finding people with drug-resistant TB? So look at the patient care cascade and where people are falling out. Once you find people, are you initiating them on treatment, or are there people being lost to follow up after their diagnosis? How many are completing their treatment successfully? What are your targets? And are you reaching your targets, or are you far from them? So how much work do you need to do? What are the gaps? And I think very important is supportive care the intervention? Are those the interventions that are going to help you fill those gaps and reach your targets? Next slide, please. Apologies, everyone. I have a little bit of a cold, so my throat is a little scratchy. So these are just some data from the Philippines 2015 cohort, looking at their indicators for drug-resistant TB. So their estimated incidence overall of MDR-TB was 30,000 people per year. And among cases, pulmonary cases notified, about 20,000 cases of drug-resistant TB. So we already see we're missing cases between the estimated incidence and among pulmonary cases because we're not diagnosing enough TB. So that's the first place in the cascade where people are falling out. You know, a third of our MDR cases are not being found because the TB is not being found, and those people are not being tested for drug resistance. Then in terms of between the cases notified and those that are estimated, we have 74% are being missed. So clearly more testing needs to be done of the pulmonary TB cases who are diagnosed. That's a major gap in case finding. But it's not something that we're going to be able to solve with supportive care. That needs a different intervention, like expansion of gene expert testing. Then in terms of being started on treatment, all of those patients, and actually a few more, were started on treatment. So there's not a deficit there. We're doing well. Once we identify cases, they're being started on treatment. Treatment success isn't bad, but it could be quite a bit better. So at 69%, that's the gap that we can influence with supportive care. Next slide, please. So that's really where we're going to focus on. So what do you do now that you have your data? Look at the factors that are contributing to low treatment success. Why is treatment success only at 69% in the Philippines? Where are we losing patients and why? So analyze and interpret whatever data you already have. Talk to people. So talk to frontline care providers, talk to patients, use any studies that you have, especially talk to community-based organizations and people with drug-resistant TB to understand why people are falling out of treatment. And then you have to make some decisions about, out of all of those things that you've heard, which factors are amenable to intervention? So where are there places that you can make a difference? What's feasible for the program to do? And out of all of the possible interventions, what are the ones that are going to have the greatest impact for the most people? And that's where I would suggest you start with implementing supportive care. So if people are falling out of care because they can't afford to continue treatment, you need to think about social support in the form of vouchers, food vouchers, transportation vouchers, direct cash transfers, ways to keep people in treatment by providing them with some sort of income, for instance. So then identify which factors can be addressed by implementing elements of supportive care and do that. That's what we're aiming for, is looking at where can we make the most difference with our supportive care package. Next slide. And I just want to make the point that when we're talking about quality care for people with drug-resistant TB, supportive care is just one of those factors. There are many different things that comprise quality care. First of all is prevention, then infection control, rapid diagnostics, trained health workers, drugs, all of the other things that go into making care of high quality. So supportive care is one element. It's not everything. It's not going to fix all of your problems if you don't have well-trained clinicians and you don't have second-line drugs. All the supportive care in the world is not going to get your treatment success to above 85 or 90%. You have to think about all of these things at once, but supportive care is what we're concentrating on in this particular package, in this particular presentation, because that's one element that's been lagging behind the others. Next slide. So the third step in this process is looking at what do you need to have any policy changes, any legislative changes to implement a care package. In a number of our pilot countries, they had to think about changing their protocols or allowing for legal frameworks to provide these services to patients. Do you have enough human resources, and are they the right codders to be able to deliver these services? Are you going to need to do some task shifting? Do you need to do some additional training? And what are your material needs? So are there resources that you would need to be able to implement a care package at the national level? So do you need space for doing it? Do you need nutritional supplements? Do you need to purchase bicycles so that people can go on home visits, etc.? All of those things. And this photograph is actually a photograph of one of our pilot sites in China, where they decided that they needed to refurbish a room to provide patient counseling services. And so they took a room in their facility and they redid it so that they could use it for patient counseling, and they hired a nurse case manager who could manage all of the people with drug-resistant TB throughout the course of treatment and follow them. So they ended up doing a number of different things. And there is a tool in our toolkit that can help you go through this process and look at what you have already and what you need. And we'll talk about that at the end. Next slide, please. So once you incorporate, once you think about what you need, then in terms of incorporating this into your national guidance or legal frameworks, there are a couple of things that you need to think about. First of all, it's useful to include this in your national strategic plan the next time you have a refresh of that plan, and then legal frameworks as appropriate for your particular context. In some countries, that's very important. Then in your national guidelines, there are a few things to cover when you think about supportive care. Who's going to receive this? Are there going to be eligibility criteria for supportive services, or is every drug-resistant TB patient going to get all these services? What do they receive? What elements are the highest priority at country level? Who will deliver these services? What are the roles and responsibilities of different stakeholders in the system? How will they be delivered? Is it going to be on an, inpatient basis, outpatient basis, community-based care? What sort of system can the country implement to make sure that supportive care is delivered in the most appropriate way, the most feasible way? What funding streams are available and will be used for implementation? And then at the national level, thinking about providing training and materials for training and providing support for implementation to lower levels of the system. So who will be responsible for supervising, providing supportive care, and how will that be arranged at the national level? And what will be the relationship with the regions and the local level? And there are also tools in the toolkit to help you with this. Next slide. The next thing, in most countries, you're not going to roll this out nationally all at once because it's difficult and it takes time to learn how to organize this system and what works and what doesn't. So in all of our pilot countries, we developed some criteria for selecting sites, and it might be, I think, one of the most important things in starting this process was finding areas that were interested in implementing patient supportive care and had some commitment from their decision makers to do so. Then sites that were ready to do implementation. So they had staff available, they were able to do training, they had supplies, they had a capacity to do the monitoring that is useful in looking at how well the package is functioning. They had high burdens of drug-resistant TB. And you might look at past performance, and it may be that you want to implement in sites that are not doing well. It may be that you want to start implementing in sites that are doing well so that you have a reasonable chance of success and you can continue improving and create a very strong model for the rest of the country. So it's going to depend on your situation entirely. This is a picture from South Africa where they started to do intervention in the red dots, and their blue dots were control sites that they compared. So they used that to compare their results to see if they had made progress. Next slide, please. So the next thing to do, of course, is to create a plan for how you're going to monitor and evaluate supportive services, and Lisa is going to talk about this. So I will turn it over to her.
Thank you, Darcy. So just again, I'm Lisa Adams. I was the epidemiologist and contributed to the working with the teams on the monitoring and evaluation aspects of the care plan pilot. So obviously you want to be able to show the success and benefits of implementing the care package to a variety of stakeholders. So of course you need to develop a plan to be able to do that. Some of the key variables that we thought were most important to evaluate were wanting to assess improvements in DRTB patient clinical outcomes as a result of implementing the care package. Obviously, you want to see that more patients are being retained in care, adhering to their treatment, and being cured. And we did this by comparing a baseline or historical cohort, comparing the outcomes of that cohort to the outcomes of a post-implementation cohort. In terms of patient satisfaction, we thought it was also important to quantify whether patients were more satisfied with care received under the supportive care package. So in order to determine that, we compared baseline patient survey results to the survey results of those who had been receiving care under the package for at least 6 months. Next, we thought it important to determine the feasibility and acceptability of implementing the comprehensive care package in each setting. And we did that by surveying the frontline clinicians and health managers, asking them about training requirements, their amount of time they were able to spend face-to-face with patients, et cetera, to determine whether they felt that this was feasible, acceptable, and a sustainable model. Now, survey samples are for each of these 3 sets of indicators are available in the toolkit, so you don't need to start from scratch by developing these. Some other things to consider are other indicators that are going to be relevant to your specific setting and specific interventions that you implement. So again, tailoring the surveys and questions that you might ask of patients and clinicians and healthcare managers, et cetera. Also thinking about indicators that will be important for your policymakers, indicators that will help you be able to more effectively advocate for scale up of the care package, such as the cost of services per patient. That might be one indicator that would resonate with policymakers. Next slide, please.
And just before we go on, Lisa, I just wanted to mention, just in terms of specific interventions, the picture there is from Pakistan, and one of the interventions that Pakistan implemented was patient nutrition. So they added an indicator of weight gain. So they tracked weight gain in these patients to see if it was making a difference providing the nutritional support. So that's just an example.
Great. Thank you. Yeah, next slide. So the next step is really making sure that you're using the lessons learned to improve delivery of supportive services. This really requires a multidisciplinary approach, and input should be sought from a range of healthcare workers and other stakeholders to encourage buy-in and ensure continuous quality improvement. This is very much an iterative process, as you probably have gathered and will hear us reinforcing over and over again. We also recommend using real-time review of the data to be able to make those, sort of ongoing interim course corrections and adjustments to how the care package is being delivered. By doing it, as you go along rather than waiting to the end, will be much more effective and I think engage the providers in a more meaningful way. Also, being sure to focus on quality and outcomes. Of course, that's what you want to be able to demonstrate, and again, across a variety of variables, including satisfaction, as well as the final clinical outcomes. And then lastly, be sure to share those results and the successes with policymakers and funders so that you can use this information to advocate for evidence-based allocation of funding and resources, especially where the benefits are clearly demonstrated. Next slide. That's our Ukrainian team, right, Darcy? the picture there.
Yes, it is. It's the Ukrainian team from one of our pilot sites.
Mm-hmm.
And I just want to reiterate that having people get together and talk about their data as they go through the process and review all of their cases really, really helped in maintaining the quality, but also it was a really good way to do quality improvement. And we found that there were a lot of health systems side benefits to implementing the care package.
Yes.
That we'll talk about in another presentation.
Exactly. And even team building, I think, came out of that process as well. By talking about the process and what needed to be changed, it really did engage all the providers across the spectrum. Yes, next slide. And Darcy, you're going to talk about this one?
I will talk about this one. So all of our pilot countries said very strongly that advocacy and sustainability were their two concerns, and two things that they wish they had planned earlier. So I can't emphasize enough that it's important to do this early in the process, to think about what advocacy you want to do and make sure that you're gathering data from the beginning that can help you make a strong case, a strong argument for continuing these services once you're finished with your demonstration. Starting with your key decision makers from the very beginning. So for instance, when China started their thinking about their interventions, the national program was there from the very beginning, discussing with them what this might look like, how they would approach it, etc., so that there was very clear buy-in. As I said, gathering the data and providing updates throughout the process, not just at the end. Make sure that you're inviting people for updates, that you're informing them about what's happening in the pilot. So as a result of the work that China did, and also in other countries, the approach was endorsed by the national TV program. So for both Ukraine and China, the NTP endorsed, and there was legislation passed or guidance issued that supported a care package approach. And in South Africa, they already had a very patient-centered approach, but it hadn't been implemented as strongly, perhaps, as it should. And in Pakistan, they're looking for additional resources now to continue implementation. But it's important. The point really is engage people from the very beginning and make sure that they're interested and aware of what you're doing. So as a result of the work that FHI 360 did in China, the national program is now implementing this approach nationwide, and they're scaling up quite rapidly. In the next several years, they will be scaling up to cover this approach nationwide. So I just want to say it is possible, but it does require a lot of planning and a lot of engagement with your stakeholders. So think about that at the very beginning of the process. Next slide, please. Okay, back to Lisa.
So just some advice and words of wisdom from the pilot country teams that we thought we would share with you. Again, some of these reiterating some of the messages that we've been emphasizing already. Take the necessary time and be patient with the process. Again, as Darcy was just saying, putting in that time up front to get the needed approvals and the buy-in at all levels is really going to be well worth it in the long run. Make this a very participatory process again. So there's that continual sort of continuous quality improvement approach, that you're continually checking in with people, that feedback is listened to and acted upon, and that will make the implementation of the care package and the feedback and the buy-in that you get from those policymakers and decision makers just a lot easier. Make sure that your frontline staff get the adequate training that they need, particularly around counseling. Sometimes that's a key element. Make sure that there's very clearly written instructions and SOPs for the teams to follow. Again, clarity and continually checking in with people, again, will go a long way. Being supportive, being flexible, again, a lot of these things we've sort of already been talking about, and being adaptable, right? You've heard that. This is a framework which is meant to be adapted to what is needed for your setting. So that does require you to be able to do the work to find out what is going to be most important in your setting. And making sure that when you have the tangible benefits in terms of better patient satisfaction, healthcare worker satisfaction with implementation and delivery of the care package, and improved clinical outcomes, that information is shared widely and really celebrated as the success of the project and implementation. Next slide, please. So again, making sure that there is at the start, a shared or common understanding of the issues and what are the challenges that patients are facing, and what is the need for providing supportive care, and what are the interventions that are going to be most effective. And again, it's often the patients and frontline providers who will be able to guide the development and the care package interventions. So again, yes, considering local needs, being realistic, but also ambitious. It's good to be aspirational about what you would like to do. And then some other more practical advice was around things like adapting and finding shortcuts for some of the tools which may at the outset seem cumbersome. So for example, the patient assessment and care plan, it's a thick document, and I think appeared a bit overwhelming for people at the start, but the teams found that if they went through the care package and care plan and began filling it out over several appointments. They didn't need to do it all at once at the first appointment. They could sort of take their time. This is an ongoing relationship that you're establishing with the patient. But then they could actually get all the information that they needed to be able to individualize and tailor care most appropriate to that patient. We've talked about the importance of multidisciplinary team approach, and that includes partnering with community-based organizations to help deliver some of the care package interventions, and that will really help the healthcare teams, healthcare workers extend their reach, and really allows you to tap on the expertise that the community-based organizations will bring to this work. Certainly in China and perhaps elsewhere, use of an electronic case-based information management system proved very useful for the teams there to be able to track patients very closely and assess their progress. And then again, that concept of using data for real-time improvements and assessments and modifications can't be emphasized enough. And then again, as Darcy was talking about with the enrollment in terms of numbers of sites, good advice overall is really to start with a few small steps, learning what works well in your setting, what needs to be adapted, determining that before you start to expand. So taking it in piece by piece, step by step, proved very useful to our country partners. Next slide, please.
Okay, so the good news is that, this may seem overwhelming to some of you who are listening to this for the first time. And I just want to say there are lots of tools out there to help you. So as part of this process, we developed a document that's in two parts. The first is the practical, what we call the practical guide. So that's just an orientation guide to give you the framework to talk about the steps in implementation generically. And then the operational toolkit that goes along with it has very explicit step-by-step instructions. There's a how-to guide for each of the 13 elements that goes through what is the rationale for this element, where can you find additional resources, how might you start implementing that particular element. And then there are templates and tools to help you do all of the things that we have talked about in this webinar. So the service status assessment and planning tool looks at what services are you already providing and where are there gaps out of those 13 elements. What are you already covering, things that you're doing now, and what else might you want to do? What else might you want to implement to cover more elements? Then the Rapid Systems Assessment tool is the template that you can use to look at what resources you might have already to do the implementation and what resources you might need in terms of what we talked about, the human resources, the training, the financial resources, etc. The local operational plan is then used to translate this into something at a facility level. So how do you actually go about doing this on the ground? And then we get down to the patient assessment and care plan template, which Lisa just mentioned, is really, to me, the most critical document of everything, is how do you deliver these services to an individual patient, and how do you monitor that over time? And then there's an M&E guide that goes along with it. You can access all of those resources for free at the website address on the bottom of that slide. And this presentation will be available to you after we're done, so no worries, you don't have to copy this down. Next slide. So I'm not going to go through all of these slides because I want to have plenty of time for questions and answers. As I said, you will have access to these slides, but this just goes through, the next 3 slides go through and talk about what is included in the toolkit and who should use these different pieces. So next slide, please. So this talks about the various pieces I just described and how you use them. And you'll have access to this. Next slide. And one more. That brings us to the end of our presentation. Now we have some time for questions and answers. We're happy to do our best, and I see that we have a couple of our partners from our pilot countries who are also online, so they might be able to help us answer some of your questions. But this is a quote from one of our partners in South Africa, who said, "We had our own dreams about how to provide patient care and address stigma and the high interruption rate. Now the patient-centered care package has made those dreams a reality." Again, this is not something new. This is something you've always done. This is just a way to think about organizing it in a systematic way to be able to see where you're doing well and where you might be able to add some things to make your outcomes even better for yourselves and your patients. So we really appreciate your joining us today. And if you have any questions, please feel free to ask them, and we will do our best to answer them. There's a Q&A on the bottom of the screen. You can click on that and write a question, or you can raise your hand. And I think Sharanya will be moderating.
Yes, I'll be moderating questions. Also, if our attendees could just take a couple seconds to fill out a small evaluation poll so we can continue to improve the quality of these webinars next time.
And just while we're waiting for people to think of questions, we will be having some additional webinars. I believe the next one is going to be specific to implementing at the facility level, facility and community level. So we'll have a couple of our pilot countries presenting as well about their experiences working at the facility and community level to implement a care package, which is incredibly helpful, I think, to countries who are thinking about doing this, and how are they going to engage with frontline providers and with community-based organizations. So keep your eyes open for that. I think it's planned for September 30th. And there may be another one in between, but I'm not sure.
Yeah, we have another webinar coming up on developing digital apps to support TB care on September 19th, as well as another webinar on the Infection Prevention Control Roadmap development and implementation coming up on September 23rd. So we will be sending out invites, so keep your eyes open for those as well.
And don't be shy. I'm sure somebody out there has a question. We certainly learned a lot through this process, and there are reports that will soon be available, if they're not already on the deck, that you can access. So we have a summary report of the results from all 4 pilot countries and what we learned through that process. And then there are country-specific reports for China, Pakistan, South Africa, and Ukraine that go into much more detail about what we learned about patient satisfaction, provider satisfaction, clinical outcomes, etc. So feel free to take a look at those as well. Okay. I see Alan has a comment. Our country has a devolved health system. Many other government agencies provided support services are likewise devolved. With this setup, we plan to pilot the care services first at the local level to see how it works before including international guidelines. Can you comment on this approach? I would say yes, that's absolutely correct, and that's what happened in all of our pilot countries. There was some work at the local level to test approaches before they were incorporated in the national guidelines. So again, the steps aren't necessarily in order that I presented. Think about what makes sense for your particular setting. In some places, they needed to have some legal basis for providing supportive care. So at the, for instance, in Ukraine, at the oblast level, they passed a prikaz to allow them to provide supportive services. But in general, especially with these devolved systems, it's important for you to understand how things work before they get included in the national guidelines. So that's absolutely a useful approach, Alan, to doing this. And it gets very complicated when you have these devolved services to engage everyone who's necessary. And that's one of the reasons that in our package and in the tools, you'll see that the first thing that we go over is how do you identify your stakeholders and who are those people at the national level or at the local level. But in all of our sites, as you said, that the approach was tested at a local level before being included in national guidelines.
And this is Lisa. I might just add too that you don't want to even underestimate the potential benefits of starting small and starting at the local level and starting with a few interventions. I felt from our site visits and feedback that we received from some of the country teams that there were often some particular services that seemed to just make a tremendous impact on patient satisfaction and well-being and ability to comply with and adhere to their treatment. Sometimes that was social assistance, sometimes that was nutritional support, sometimes it was the counseling service, either one-to-one with a healthcare provider or through peer support. So I just think it's, starting small and starting at the local level makes a lot of sense, and you can definitely see significant impact that way.
And I would also say that we piloted this approach in 4 countries, but the implementing partners we worked with were not starting from scratch with this pilot, because many of them had been implementing a patient-centered approach previous to the pilot. So they had spent some time already trying to develop patient-centered care, working with their stakeholders in country. So we weren't starting from scratch in this pilot in China or Ukraine or South Africa or even in Pakistan, where they had been implementing but had lost some Global Fund funding, so things had been less robust for a while. But again, it does take time, and I think the time and patience is the most important. You're not going to see results immediately necessarily, because it does take a while to develop this package and to train people. And I think there were some surprises along the way in our pilot countries in terms of what was needed. I think, for instance, in China, they discovered that implementation at the site level was difficult for clinicians and providers who didn't have a lot of counseling training, and that they needed to provide more support for that aspect of care more than anything else. And they spent a lot of time with individual sites. They did specific trainings on counseling, and that really supported the people on the ground. So there will be some surprises along the way, and it's important, again, just to look at your data, to have conversations with implementers, and to make sure you're doing this in a quality way. Any other questions? Any other comments from any of our implementing partners who are on the call? I see we have some folks from Pakistan and Ukraine amongst the attendees. Do you have anything you'd like to add in terms of what's important to think about at the national level?
Mm-hmm. And we have a partner from South Africa too.
Oh, yes.
Any words of encouragement for the others that are on?
I think you'd have to raise your hands to be able to comment so that you can be unmuted.
Hello.
Yes.
Hi, we've unmuted you.
My name is Farhan, and I'm one of from MDR-TB survivor in Indonesia, and I'm also a member of an MDR-TB former organization in Indonesia. And I'm thank you for the presentation, and it's I'm really interesting about your presentation about physical comfort, safety, and wellness among GRTB patient, maximize and psycho-emotional support and protection from social isolation or discrimination strengthen. So can you tell me more about this? Because like the one that you have read it with red color, like physical rehabilitation and end of life care. I think it's very necessary for us after complete the treatment, because I was realized that there's something that we have to rehab. Sorry, my English is not that good. So I really interesting about that. Maybe you can explain more about that.
Sure, sure, absolutely. Thank you very much for your question, Farhan, and thank you very much for joining us. First of all, I just want to say that we're going to have a presentation that covers implementation at the facility and community level that will cover some of these interventions in more detail. So that will be on September 30th. And in the meantime, so what we tried to do with the care package was to recognize all of the things that people with multi-drug resistant TB could need or want as part of their supportive care and treatment. And clearly, physical rehabilitation after cure was one of them. It's an area that is probably the least developed, along with end of life care in most countries, because people have been focusing on getting people treated and not thinking about the consequences of that treatment and how to support people after cure who have experienced some lasting side effects or adverse effects. So it's part of the care package. There are resources for each of these areas. That's the area where we find the least resources in terms of pulmonary rehabilitation, in terms of dealing with hearing loss and vision loss and all the rest of it. But it's an aspect that we felt was really important to include, and it gives some suggestions about how to start. But again, it's an area that's probably the least developed, and we need some more guidance in that area. And I'm hoping that I know that WHO was working on some guidance, so I don't know where that stands right now, but I think it's something that we need to talk about some more. But it's definitely included as part of the care package. And as I said before, countries decide what's feasible for them to implement. It's something that I think it's useful to advocate for, as patient groups in particular. Former patients have more authority to advocate for support for those sorts of services. So to the extent that you can document what patients are needing and wanting, that's really helpful in being able to advocate for including those services in a care package. I don't know if you have anything you want to add, Lisa, or Princess, or...
No, I think that was great. I think this is obviously a critical issue for many country programs. And so it's often one of the things that I think happens a little bit later. It feels a little bit more challenging to try to address, but I think it's something that is being recognized now as one of the next frontiers, one of the next areas that deserve some attention in providing supportive care to these patients.
Okay, anybody else?
We have
Go ahead.
one more question, actually.
Okay. I can see Alan has, did anyone apply the same package for, yes. Okay, so Alan asked, in the implementation sites, did anyone apply the same package for drug-susceptible TB patients? Our drug-susceptible TB patients also experience significant catastrophic cost, even if they have better treatment success, and they still experience stigma and discrimination. This is very true. And in the care package guidance documents, it says very clearly that this is not an approach that's limited to drug-resistant TB patients. It's also pertinent for people who have drug-sensitive tuberculosis. And I would suggest you could use it for anybody who has a chronic disease or a disease that needs to be treated over long periods of time. It's just an approach to patient care. So you can use it with any group of patients. This is particular to tuberculosis, but the same approach can apply to anyone who needs to be in contact with the health system for long periods of time. If you have diabetics, if you have people living with HIV, all of those things can be helped with this sort of approach. In some of our sites, it was recognized that this approach could be used for drug-susceptible TB patients, especially those who were at risk of loss to follow-up. And they have done so in some sites in China and certainly in Ukraine. So yes, the answer is yes, that this can be used for drug-susceptible TB patients, and I encourage people to do that.
And that is actually the end of our time. Thank you everyone for joining today. Thank you Darcy and Lisa for leading such a wonderful presentation. We will be sharing this presentation as well as a recording of the webinar to all of your emails. If you have any more questions, please feel free to email us at tbcare2@urcchs.com. Thank you very much.
And please share it with your colleagues who couldn't join us today.
Yes, please.
Indeed. Thank
All
you.
right, thank you everyone.
Thank you.
Appreciate
Goodbye.
it. Bye-bye.